So there are a lot of labs working on immune system because, of course, it's the hot topic. And there are a lot of people exploring the immune system as a marker for many aspects of the disease. The problem right now with the immune system is that, as I said before, the technology we have, single-cell RNA, for example, I don't think is as reliable as people claim. Meaning, as I said before, you get 1,000 cells for an immune system that is based on 1 million. You take a peripheral blood vial that could change from, just because the patient had a fever or got like dexamethasone, like one pill from the GP the day before. And so all these changes are very complicated data, are extremely valuable, and it's amazing. We're generating a lot of them. But what I'm saying is that to say to a patient, you are sensitive to this drug or sensitive to another, you need a marker that is stable and reliable. I think right now, the reliability of single-cell RNA is still far to be applied in clinic. So for patients, I think what they will see in clinic coming sooner are DNA tests, whole genome sequencing, whole exome sequencing, those platforms that will replace FISH. That's what we are working. It's going to happen very fast. The single-cell RNA, it's more complicated. It's very expensive. So I don't see that as an option for patients. Whatever people say, that's my idea. But because of this complexity, lack of standardization, it's hard to reproduce data from other labs. The multiplex staining that Emory presented is definitely very intriguing. But computationally, like working on computer on those data, it's very difficult. And so the idea is that while in the DNA we know more, we have better standardized approaches, and the DNA is stable. If the myeloma has 414, it will have 414 for the entire life. So whatever cells you get, 414 will be there. While the immune system is more like heterogeneous and can change to every perturbation. So if you want to really understand in a clean and reliable way, I think DNA right now, it's more informative for clinical application and to explore clinical outcome. In immunotherapy, be specific CAR-T, immune system can still be important, but we are in the paradox where people investigated more the immune system than the tumor cell in a lot of CAR-T studies, forgetting then the problem is the tumor cell, and maybe the immune system is so altered because of the tumor cell. And so these are like a lot of questions, mostly doubts, because science needs to doubts all the time, create hypotheses, and criticize other people's work and our own work, be extremely critical eye. And so over this process, there is a lot of studies. It's a competing community, people saying immune is important, other people that is not. I'm more like in the middle. I think it's important once it's connected to the DNA alterations. Alone, it's informative, but I think it's still far from a clinical application. So my lab in Miami, it's working exactly on that. So we have a different range of studies that are focusing on understanding progression from precursors to myeloma, developing individualized prediction model for multiple myeloma that are right now DNA-based, because to develop this model that are based on artificial intelligence, you need thousands of patients. And so we don't have the budget, the samples to do single-cell RNA, for example. So it's also like what we can do today and what we will do tomorrow. So in the next years, we'll generate thousands of patients. But right now, we have thousands with DNA. So that's our prediction model. And that's a new approach, for example. I think it's very powerful in the paper we submitted over the next weeks. And the idea is that ISS, R2-ISS, all these scores are relative scores. So you get your patient in your ambulatory and you say, you are ISS2. The patient doesn't know what this means. Go online and say 40% survival at 5 years. And of course, we'll say where I will be. I'm going to die in the first year, in the second year, in the third year, or I'm going to be still alive in the fifth year. So the scores are based on the fact that we assign a patient to a group, and we say that group goes in that way. The group is extremely heterogeneous. So it's useful because once you define who are the high risk, you know those patients are high risk. Not all of them, but many of them. But all intermediate and low are basically we don't know. And these psychologically affect a lot the patients. I always say when I meet patients, and there is always a patient say, I was ISS3 at diagnosis, but I'm in remission after 5 years. And I always reply, that means you were not high risk. Like high risk are the ones that progress within 1 year, 2 years. They're like almost 20% of the patients in our model progress during treatment or stop the treatment for some reason. We have in the Compass, 15% die in the first 2 years. So we have a group of patients that we don't even enroll in clinical trials. Those are missed from our studies. And so those are the ones that we need to think about, how we can represent this in our studies. Instead of reaching MRD to 90% or CR in 100%, we should focus on the real populations where we know we are failing. And we need to build model to predict that population. So our model predicts individualized risk, which means you come in my ambulatory with myeloma, and I get the genomic screening, and I can tell you your risk according to the different treatments, including transplant, no transplant, maintenance, no maintenance. And I can predict your risk with an accuracy more than 0.7, which is kind of like not perfect, but good. I don't think this is gonna be used for clinic, but that's a kind of like a turning point, because we move from relative risk, all the patients are the same, just divided by some bunch of serological features for group, to an individualized model, where according to who you are and what you have, we can predict which treatment we should get you. That's a big deal, because instead of saying transplant or transplant because I like it or don't like it, you say transplant or transplant because it gives you 10 or 15% more risk to not progress at 5 years, for example. So that's what our model says. And then we have like much more complicated analysis on, we look whole genome sequencing, new drivers, new alterations, resistance to new drug, in particular immunotherapy. We're working a lot with different groups to try to understand why CAR-T fails, why bispecific fails, and how we can identify populations that can benefit from one or the other, right? Because we have two. And it's difficult to compare, also because the CAR-T needs 28 days to get the CAR, and a lot of patients don't even are eligible. Actually, those are the high risk, right? The one that cannot. So there is always a little bit difficulties to interpret the data also sometimes. But I think we are trying to covering a lot of aspect of myeloma biology, starting from a DNA, with its interaction with the microenvironment, with the microbiome, with the images and multiplex staining. And the idea is to get as much information as possible to identify which are the key information we need to bring to the patient. Our model identifies 17 genomic features right now using exome sequencing. 17. You don't need 200, just 17. Those are the 17 genomic alterations that are important in our model. When we put 1,000 genomes, we will have maybe 30. But this kind of like allow you to create also like tools to test which features we should check. Not all centers around the world. This is America. We have a lot of money to spend and to waste sometimes. So the idea is that here everybody can do sequencing. But like, let's say Europe, Italy, where I come from, it's impossible to get the sequencing platform for myeloma for every patient as I want to establish here in America. So we should create surrogate to allow people. I'm not saying like, what they are called like developed country or like Western countries. So country where an extremely well-funded health system like Italy, Germany, they will not fund this kind of enterprise. So we need, because patients probably will need that. That's our belief. We need to create surrogate for that. So cheaper technology, more like reliable that they can use. So that's also part of different grants with Garrett Morgan and others to try also to get this information straight to the real population, not just the fancy academic American hospitals.
How is survival predicted, and does it predict what drugs you'll have a better chance of responding to?
It generates, we have 32 different treatment combinations, 8 different cycles, plus 4 different consolidation strategies, transplant maintenance, only maintenance, nothing. So you have 32 possible combinations. So our model allows you to predict the outcome, which means survival and remission, and other. It's a little bit more complicated than that, but let's say survival and progression according to the 32 different treatments. So for each patient, you can generate 32 different predictions.
And they can pick which
We
one
call
is
treatment
best.
variance. Let's say you treat the patients with thalidomide without transplant. I don't even know if we have enough data because it's based on artificial intelligence. So you need enough data in your model so the algorithm learn from that and transfer the information when you try to predict something. So like thalidomide without transplant, and you compare with KRD plus transplant plus maintenance, the difference is 25%. And that's huge, right? For a patient also to see it.